Right now, before you do anything else, I want you to swallow. Do not reach for your water bottle. Do not clear your throat. Just swallow naturally, the way your body does it without thinking. Now pay attention to what just happened. Did your tongue move smoothly across the roof of your mouth? Or did it drag slightly like it was pulling against something sticky? Did the back of your throat feel moist and easy? Or did it feel tight, coated, a little like sandpaper? Did that swallow take half a second? Or did it take longer than it should have and now you're already thinking about getting a drink? That tiny sensation you just noticed, that small, almost invisible signal from inside your own body, is something millions of adults over 60 experience every single day. And almost every single one of them has been told, at some point, not to worry about it. I want to spend the next hour changing that. My name is Dr. Megan Foster. I have spent over 2 decades working in senior health, and in that time, I have sat across from thousands of patients who came to me with serious, complicated, difficult to explain health problems. And when I look back at the full picture of their health histories, one symptom appears again and again in the background, quietly, before the bigger problem ever showed up. Chronic dry mouth, not occasional dryness, not the kind you get after a long run or a salty meal. I am talking about persistent, recurring, daily dryness that does not go away with a glass of water. The kind that is there when you wake up. The kind that makes crackers feel like chalk. The kind that has slowly, so slowly you barely noticed, started to feel normal. Most people believe dry mouth is one of three things. They think it is just part of getting older. They think it is mild dehydration, or they think it is a minor side effect of some medication they take, something listed in tiny print on a pamphlet they threw away. What I'm going to tell you today is that in a significant portion of cases, none of those explanations is fully correct, and more importantly, none of them is the whole story. Dry mouth, the medical term for it is xerostomia, is rarely just dryness. It is often a signal. And like most signals the body sends, it means something specific depending on when it appears, how it feels, what it comes paired with, and how long it has been going on. Ignoring that signal does not make it quieter. It just means you are not listening until something louder gets your attention. I want to give you that context today. Not to frighten you, but because you deserve to understand what is actually happening inside your body and what, if anything, can be done about it. Let me start with something I ask almost every patient I see over 60. Think back 10 or 15 years. Do you remember waking up and just talking? No clearing your throat first. No dry cough before your voice came in. No reaching for the bedside glass of water before you even said good morning. You just woke up, opened your mouth, and your voice worked. Think about eating. Toast, crackers, a piece of bread with nothing on it. You did not need a sip between bites. You could talk during a meal without feeling like something was sticking to the inside of your mouth. Meat was not difficult to chew. Swallowing was not something you thought about at all. Most of my patients say yes when I describe that. And then I ask them when it changed, and almost all of them say the same thing. They are not really sure. It was gradual. Nothing happened dramatically. They just started keeping water nearby more often, and at some point, that became the new normal. That quiet, gradual shift is exactly what makes this condition so easy to miss and so important to understand. Here's something that surprises a lot of people when I tell them. Your salivary glands do not simply slow down because you got older. Aging does affect many systems in the body, but significant xerostomia is not an inevitable consequence of turning 60 or 70. In the vast majority of cases, something specific is suppressing salivary function. And when that something is identified and addressed, improvement is often possible. That is not a guarantee. Bodies are complicated and every situation is different, but the framing matters enormously. If you believe your dry mouth is just aging, you will manage it. You will buy special rinse, keep water on your nightstand, and accept it. If you understand it might have a correctable cause, you will look for it. Let me explain what saliva actually does because most people have no idea how much their body depends on it. Saliva is not just wetness. It is not there to help food slide down more easily, though it does do that. Saliva has three distinct and critical functions that operate every hour of every day, whether you are aware of them or not. The first function is protection. Your saliva contains proteins that coat the surfaces of your mouth, your throat, and the upper part of your digestive and respiratory pathway. That coating acts as a barrier. It keeps bacteria from attaching to surfaces. It neutralizes acids that would otherwise erode your teeth and gum tissue. And it provides a chemical environment that is actively hostile to the kinds of organisms that cause infection. Think of it like a security coating on every surface inside your mouth. Invisible, constant, essential. The second function is bacterial control. Your mouth is never sterile. At any given moment, hundreds of species of bacteria live in your oral environment. In a healthy mouth, saliva keeps that population balanced. It suppresses the harmful bacteria while allowing the harmless ones to coexist. When saliva decreases, that balance breaks down. Harmful bacteria proliferate. They form thicker films on teeth and gum tissue. They travel further back in the mouth toward the throat. And at night, when you are lying down and your swallowing rate naturally drops, they migrate. This leads to the third function, which is one most people never consider at all. Think of your mouth and throat as a corridor that connects to your lungs. During the day, you swallow frequently and the muscles in your throat are active, constantly clearing that corridor. At night, swallowing slows dramatically. Small amounts of bacteria and oral fluid drift backward during sleep. This is called microaspiration, and it happens to everyone to some degree. It is a normal physiological process. In a person with healthy saliva production, the bacterial load in the mouth is low, the pH balance is maintained, and the microaspirated material is largely harmless. The lungs can handle it. The immune system of the airways manages it without any problem. In a person with chronic dry mouth, the bacterial load is much higher, the balance in the oral environment is disrupted, and what gets aspirated is more concentrated and more harmful. Night after night, over months, this accumulation shifts the risk profile for respiratory infection, particularly aspiration pneumonia, which is among the most serious infections older adults face. This is not a theoretical risk. It is a well-documented physiological process, and it is one of the main reasons chronic dry mouth is taken seriously in geriatric medicine. A 2022 analysis published in the Journal of the American Geriatric Society looked at thousands of adults over 60 with confirmed chronic dry mouth. The findings were striking. This group had significantly higher rates of aspiration pneumonia, higher rates of hospitalization from respiratory infection, increased frequency of unexplained weight loss, and more frequent complications related to medication toxicity. A separate large U.S. cohort study of over 12,000 seniors found that people with persistent xerostomia were nearly 3 times more likely to be hospitalized for a respiratory infection within 2 years of their dry mouth being documented. 3 times. That is not a cosmetic symptom. That is a physiological risk marker. And the reason it matters so much is that it is not dramatic. It does not announce itself. It builds slowly. And then one day, something happens that seemed to come out of nowhere when in fact it had been developing quietly for a long time. Now I want to do something specific. I want to give you a framework for understanding dry mouth not as one single condition, but as 7 distinct patterns, each of which points toward a different underlying issue. Because the pattern matters more than the dryness itself, the pattern tells you where to look. And when you know where to look, you can ask the right questions. Let me start with the one that is least urgent but most misunderstood. Dry mouth that appears only in the morning. You wake up and your mouth feels terrible. Dry, thick, almost sticky. But by mid-morning, after you have had some water and maybe breakfast, it mostly resolves. The rest of the day is reasonably normal, and so you assume it is just nighttime dehydration. You drink less before bed to avoid getting up at night, and you keep a glass of water on the nightstand. Here's what is actually going on in many of those cases. When someone breathes through their mouth during sleep, the continuous airflow strips moisture from the oral surfaces at a much faster rate than nasal breathing does. By the time you wake up, the mouth has been functioning as an air duct for 6 to 8 hours. The dryness is severe not because your body stopped producing saliva, but because everything produced during the night evaporated before it could do its job. The question is why you are mouth breathing in the first place. In a significant percentage of adults over 60, nighttime mouth breathing is a sign of airway obstruction during sleep. The nasal airway becomes partially blocked, the body shifts to mouth breathing to compensate, and a cycle develops. This pattern overlaps substantially with undiagnosed sleep apnea, which is one of the most underdiagnosed conditions in older adults, particularly in older women who are often told their symptoms are just stress or insomnia. Sleep apnea and its associated airway disruption have well-established connections to elevated cardiovascular risk, cognitive decline, and metabolic disruption. The dry mouth you notice every morning might be the most visible symptom of a nighttime breathing problem that is affecting your heart and your brain without you knowing it. The common mistake is treating the dryness with water instead of evaluating the airway. If you wake consistently with a dry mouth and a dry throat, especially if you snore, feel unrefreshed in the morning, or notice fatigue that does not improve with more sleep, that pattern warrants a conversation with your doctor about a sleep study. Now let us move to the second pattern. Dry mouth combined with frequent urination at night. You wake 2, 3, maybe 4 times to use the bathroom. Your mouth is dry each time. You assume this is an aging bladder. Maybe you have even been told that, and it might be. But when these two symptoms appear together consistently, they can be telling a different story. High blood sugar pulls water out of your body's tissues. It draws fluid from the cells and pushes it into the bloodstream, and then the kidneys work to excrete that excess through urine. This process, in addition to causing frequent nighttime urination, also draws fluid away from the salivary glands. The result is reduced saliva production at the same time as increased urinary output. Large population studies have documented a strong correlation between xerostomia and poorly controlled blood sugar in older adults. And the reason this matters so much is that diabetes in its early stages and even in its well-established stages is often less symptomatic than people expect. The dry mouth and the nighttime urination, taken separately, both seem explainable. Together, they form a pattern worth investigating. If you experience this combination regularly, ask your doctor for a fasting glucose test and an HbA1c measurement. The HbA1c shows your average blood sugar over the previous 3 months, which gives a much more complete picture than a single reading. The mistake here is dismissing each symptom individually when the pairing is the signal. The third pattern is one that often gets overlooked for years because it involves two different parts of the body and they seem unrelated. Dry mouth alongside dry, gritty, irritated eyes. You use eye drops. Your eyes burn in the afternoon. Bright light bothers you more than it used to. And your mouth is dry in a way that does not fully resolve. Maybe you have some joint stiffness in the mornings. This combination is one of the classic presentations of Sjogren's syndrome, an autoimmune condition in which the body's immune system mistakenly attacks the moisture-producing glands, including salivary glands and tear glands. Sjogren's is significantly underdiagnosed, particularly in older women. The symptoms develop slowly. They are easy to attribute to aging or dry climate or screen time, and many primary care providers do not immediately connect dry mouth and dry eyes as a potential autoimmune pairing. The critical distinction here is this. In dehydration, you add fluid and the problem improves. In Sjogren's, The glands themselves are being suppressed by immune activity. Adding fluid helps symptoms temporarily, but does not address the underlying process. This is not dehydration. It is gland dysfunction caused by the immune system. Autoimmune screening can identify Sjogren's in patients who have been living with these symptoms for years without a diagnosis. And once diagnosed, there are both medical and supportive management options that can meaningfully improve quality of life. The mistake is assuming that eye drops solve the underlying cause of the dry eyes and that the dry mouth is just a separate, unrelated issue. The fourth pattern involves the relationship between saliva and nutrition, and it is one of the most underappreciated connections in geriatric health. Dry mouth combined with unintentional weight loss. Saliva does not just make food easier to swallow, it begins the digestive process the moment food enters your mouth. Salivary enzymes start breaking down starches and signaling the digestive system to prepare for incoming nutrients. Without adequate saliva, that initial stage of digestion is incomplete. Beyond that, when eating is uncomfortable, when every bite requires effort, when certain textures become difficult to manage, people naturally begin avoiding those foods. Tough meats, raw vegetables, dry breads, foods that require extensive chewing. Over time, the diet narrows, and what looks like reduced appetite or picky eating is actually an adaptive response to discomfort. Studies have found that close to half of seniors with unexplained nutritional deficits or unintentional weight loss report chronic dry mouth as an ongoing symptom. The weight loss is not dramatic at first, a few pounds here, a gradual reduction in portion size there. But over time, it adds up, and the consequences, including muscle loss, immune suppression, and increased fall risk, become serious. The point is that you can be eating 3 meals a day and still be losing nutritional ground because the process of extracting nutrients from food is compromised. The fifth pattern is more subtle and more easily dismissed, but it is important. A change in the quality of saliva rather than a simple decrease in volume. Some people do not describe their mouth as particularly dry. They describe it as sticky. The saliva that is present feels thick, ropey, almost elastic. It does not feel like it is coating and lubricating the way it should. It feels like it is getting in the way. This texture change is not the same as low saliva volume, and it points to a different kind of problem. When saliva becomes thick and stringy, it often reflects a change in the composition of what the glands are producing, rather than a reduction in how much they produce. This can be a sign of gland dysfunction, or it can be an early marker of autoimmune activity affecting the glands. People with this pattern sometimes do not report dry mouth at all because the mouth does not feel empty of moisture. It feels coated in something that does not work the way normal saliva should. This is why asking specifically about texture, not just dryness, is important in any medical conversation about this topic. The sixth pattern is one of the most actionable and, unfortunately, one of the most commonly overlooked in clinical practice. Dry mouth that began or significantly worsened after a medication change. Over 500 medications list dry mouth as a known side effect. These include many antihistamines, blood pressure medications, antidepressants, bladder medications, sleep aids, and a wide range of other commonly prescribed drugs. On their own, these medications might cause mild dryness. But here's where it gets more complicated. When you are taking 3, 4, 5, or more medications that all have anticholinergic effects, meaning they work partly by blocking a certain chemical signal in the nervous system, the suppression of saliva does not add up the way you might expect. It multiplies. The combined effect is significantly greater than the sum of the individual effects. This is called cumulative anticholinergic burden, and calculating it properly requires looking at the full medication list together, not each drug individually. Most routine prescription reviews do not do this calculation. A medication that seemed manageable on its own, added to an existing combination of 3 others, might push the total burden to a level that causes significant dry mouth, along with other effects including constipation, confusion, and urinary retention. If your dry mouth developed or worsened after starting a new medication, or after your medication list grew, this pattern is worth investigating. Ask your doctor or pharmacist to review your full medication list specifically for cumulative anticholinergic burden. It is a specific question, and it often yields actionable answers. Now we come to the final pattern, the one I spend the most time discussing with patients and their families. The one that, when I look back at hospital admissions and serious respiratory events in older adults, appears in the history more often than almost any other chronic symptom. Chronic dry mouth combined with repeated chest infections. Not one pneumonia, not one bronchitis that resolved cleanly. A pattern. 2 or 3 respiratory infections in a year. A cough that does not quite go away. A chest that feels congested more often than it should. An antibiotic course that works, but 6 months later, another infection starts. When this pattern exists alongside long-standing chronic dry mouth, the mechanism I described earlier, microaspiration, is almost certainly part of what is happening. Every night. Bacteria-rich oral material, without the buffering protection of adequate saliva, drifts into the lower airway. The lungs respond with low-level inflammation. The immune system of the respiratory tract works harder and harder to manage the constant exposure. Eventually, one aspiration event, one night when the bacterial load is higher than usual, one moment when the body's defenses are slightly depleted, tips into an actual infection. Aspiration pneumonia does not always look like classic pneumonia. In older adults, it can present as fatigue, confusion, low-grade fever, reduced appetite, or a gradual decline in function that does not have an obvious cause. It can be subtle enough to be missed or attributed to something else entirely. Geriatric research consistently identifies chronic xerostomia as a significant independent risk factor for aspiration pneumonia and ICU-level respiratory illness in adults over 65. The word independent here is important. It means that even when you account for other factors, the dry mouth alone carries measurable risk. Understanding this pattern is not meant to frighten you. I want to be clear about that. It is meant to give you a framework for having a different kind of conversation with your healthcare provider. Not a conversation about discomfort, a conversation about respiratory risk. Those conversations get different responses, and they lead to more thorough evaluations. Now, I want to shift to something that tends to surprise people. When the underlying cause of dry mouth is identified and addressed, the response from the body can be faster than most people expect. Salivary glands are resilient. They are not like some other tissues that, once damaged, do not recover. When the suppression is lifted, whether that means adjusting a medication combination, treating an underlying metabolic condition, managing an autoimmune process, or addressing a breathing problem during sleep, the glands often begin to recover meaningful function within weeks. Patients describe the change in specific ways. The morning swallow becomes easier. The voice is clearer in the first half of the day. The need to cough and clear the throat before speaking reduces. Food tastes better because taste perception is partly mediated by saliva. Meals become easier and more enjoyable. These are not dramatic transformations. They are quiet improvements in daily function that add up to a meaningfully better quality of life. I also want to address something I hear frequently from patients who have tried to raise this with their doctors before and were dismissed. If someone has told you that your dry mouth is just part of aging, you have every right to push back on that, politely, specifically, with a clear question. You can ask, is there any possibility my medication combination is contributing to this? You can ask, is my dryness pattern consistent with a systemic cause that warrants investigation? You can ask, should we evaluate my nighttime breathing? You can ask for a fasting glucose and HbA1c if you also experience nighttime urination. You can ask whether your dry eye symptoms and dry mouth together could suggest an autoimmune process. These are not confrontational questions. They are focused, informed questions. And a good clinician will engage with them seriously. You are the person who lives in your body. You know when something has changed. The information you carry about your own experience is diagnostically valuable, and you have every right to make sure it is heard. There are also some daily habits worth understanding because they directly affect how much saliva your glands produce during the day and especially at night. Breathing through the nose during sleep is one of the most protective things you can do for oral health, respiratory health, and salivary function. Many people do not realize they are mouth breathing at night until a partner mentions it, or until they notice the morning dryness pattern we discussed. If you suspect mouth breathing, a conversation with your doctor about nasal airway health, allergies, or a sleep evaluation is a reasonable starting point. Alcohol, including alcohol containing mouthwashes, has a drying effect on oral tissues. Many older adults use antibacterial mouthwash as part of a nighttime routine, not knowing that the alcohol content, which is quite high in many commercial mouthwashes, contributes to overnight dryness and disrupts the oral bacterial balance in ways that can actually make the overnight microaspiration problem worse, not better. Alcohol-free mouthwash options are available and worth switching to if you use mouthwash regularly. Caffeine is a mild diuretic and also has a drying effect on mucous membranes. This does not mean eliminating coffee, but understanding that a strong cup of coffee in the evening might be contributing to overnight dryness is useful information. Certain supplemental nutrients are involved in maintaining mucous membrane integrity and salivary gland function. Vitamin A, zinc, and certain B vitamins have all been studied in relation to oral tissue health. Deficiencies in these are not uncommon in older adults, particularly in those whose diets have narrowed due to appetite changes or difficulty eating. If you have had unexplained weight loss or significant diet changes, asking your doctor about a nutritional panel is reasonable. Oral hygiene also interacts with dry mouth in ways that create a cycle. When saliva is low, harmful bacteria grow faster. Faster bacterial growth leads to more gum inflammation. Gum inflammation is associated with systemic inflammation and has been studied in relation to cardiovascular disease and cognitive decline. This is why oral health is not a separate category from overall health. It is connected to the rest of the body in ways that matter. People with dry mouth also develop dental cavities faster because one of saliva's primary functions is to remineralize tooth surfaces and neutralize the acids that bacteria produce. This is why people with xerostomia often report a rapid decline in their dental health, even when their brushing and flossing habits have not changed. It is not poor hygiene. It is the absence of the protective chemistry that saliva normally provides. I also want to explain something not widely understood about the connection between the mouth and the brain, relevant to dry mouth in a way most people would not expect. Your sense of taste depends heavily on saliva. Taste compounds in food must dissolve in saliva before they can reach the taste receptors on your tongue. If saliva is significantly reduced, those compounds do not reach the receptors effectively. The result is a dulling of flavor. Food tastes flatter, less satisfying, sometimes slightly off. When this happens gradually, people often do not identify it as a taste problem caused by dry mouth. They just start finding food less appealing. They eat less. They gravitate towards saltier or sweeter foods because those flavors are strong enough to cut through the dulled perception. And over time, that dietary shift creates its own downstream health effects. The connection between dry mouth and appetite loss in older adults is real. It affects both the physical mechanics of eating and the experience of eating, and they reinforce each other. There is another dimension of this topic that rarely gets discussed outside of clinical settings, and I think it deserves more attention. Dry mouth affects social engagement. When speaking becomes uncomfortable because your mouth feels dry and sticky, people talk less. When eating at restaurants or with family becomes difficult or embarrassing, people start declining invitations. When the effort required to get through a meal outweighs the pleasure, meals become functional rather than enjoyable. Social isolation in older adults is a well documented driver of cognitive and physical decline. And while dry mouth is obviously not the only cause of social isolation, it contributes to it in ways that are rarely acknowledged or addressed. When a patient tells me they stopped going to family dinners or they feel self conscious talking at length, that is a quality of life loss that deserves to be taken seriously, not managed with a bottle of water. I also want to briefly discuss the relationship between dry mouth and medications in a slightly different way, because I think there is something most patients do not fully understand about how medication management works in older adults. As the body ages, the kidneys and liver process medications more slowly. The same dose of a drug that was appropriate at 50 may produce different, more concentrated effects at 70. This means that even a medication you have been taking for years without obvious problems can begin contributing to dry mouth and other anticholinergic effects simply because your body's ability to process it has changed over time, not because anything about the prescription changed. This is one reason why a medication review that made sense at 60 should be revisited at 70 and again at 80. The question is not just what is on the list, but how your body is responding to that list right now at your current age with your current kidney and liver function. This conversation with your doctor or pharmacist is not about criticizing your prescribers. It is about the fact that medication management in older adults is genuinely complex, and staying on top of it requires active participation from the patient. Let me give you something practical to take out of everything we have discussed today. For the next 30 days, I want you to track 3 things. Write them down, put them in your phone, whatever method works for you. First, track your morning dryness level. Use simple categories: mild, moderate, or severe. Just a single observation every morning before you have had anything to drink. Second, track how many times you wake up at night to use the bathroom, not an estimate, the actual number each morning. Third, note any changes in your medications, any new prescription, any dose adjustment, any supplement added or removed. At the end of 30 days, you will have a document that shows patterns, and patterns are what make the difference between a doctor visit where you say, "My mouth has been dry," and a doctor visit where you say, "My mouth has been severely dry every morning for 30 days. I wake up an average of 3 times a night, and this started around the same time my blood pressure medication was adjusted." The second version of that conversation is far more likely to lead to an actionable response. Here's the core of everything I want you to take from today. Dry mouth is not the problem. Dry mouth is the alarm. The actual risks are what the dryness allows to happen. When saliva drops, the protective coating on your oral and respiratory surfaces breaks down. Bacterial balance shifts. Overnight, those bacteria travel further than they should. Over time, that exposure increases the risk of respiratory infection, nutritional decline, medication toxicity, and immune activation. None of that is visible. None of it feels dramatic. It accumulates in the background while you manage the dryness symptom on the surface without ever addressing what is underneath. You have spent decades learning to recognize the signals your body sends. A pain that is different from usual. A change in how you feel in the morning. An energy level that has quietly shifted. You notice these things because you have lived long enough to know what is normal for you and what is not. Dry mouth is the same kind of signal. It is not a complaint, it is information. And the difference between treating it as a nuisance and treating it as a signal might be the difference between managing it indefinitely and actually improving it. You already took the first step today by staying and listening to this. I want to add one more layer here because it connects several of the patterns we have talked about in a way that makes the whole picture clearer. The nervous system controls salivary gland function. Specifically, the parasympathetic branch of the nervous system, which is responsible for rest and recovery states, is what tells your salivary glands to produce saliva. When the body is in a chronic state of low level stress, or when the nervous system balance is disrupted by sleep problems, by pain, or by certain medications, parasympathetic activity decreases. And when parasympathetic activity decreases, salivary production decreases. This is why people often notice their dry mouth is worse during periods of stress or poor sleep, and better during genuinely restful periods. The nervous system is directly regulating gland output in real time. This means lifestyle interventions that improve nervous system recovery, things like consistent sleep schedules, moderate daily movement, and managing untreated pain, can have a genuine positive effect on dry mouth severity. Not because they directly target the glands, but because they change the nervous system environment in which the glands operate. I mention this not to suggest lifestyle changes alone will fix significant dry mouth caused by medication burden or autoimmune activity. They will not, but they are part of the full picture, and they are things within your control. Let me talk briefly about what happens in the mouth over the long term when xerostomia is unaddressed, because understanding the progression helps motivate action. When saliva is chronically low, the bacterial population in the mouth shifts over months and years toward more harmful species. These bacteria produce more acid, and that acid accelerates the breakdown of tooth enamel. People with long-standing dry mouth often experience cavities in locations they have never had them before: at the gum line, on root surfaces exposed by gum recession, in places that were previously healthy for decades. This is not a dental vanity issue. Tooth loss affects the ability to eat, which affects nutrition. And the bacteria involved in severe dental disease are among the same families linked to cardiovascular risk in research examining the relationship between oral and heart health. Beyond teeth, gum disease progresses faster in a dry oral environment. And chronic gum disease has been studied extensively in relation to systemic inflammation, which is a contributing factor to a wide range of conditions, including heart disease and cognitive decline. The mouth is not a separate compartment. What happens in it is connected to what happens everywhere else in the body. Chronic dry mouth, left unaddressed, can become the starting point for a cascade of health consequences that seem unrelated until you understand the common thread. Now, I want to say something important. Most people in their 60s and 70s who have had chronic dry mouth for years have not developed aspiration and pneumonia. Most have not experienced serious dental destruction or significant nutritional decline. The body has remarkable resilience, and the risks I have described are elevated risks, not certainties. But elevated risk is worth taking seriously. The people most likely to see that risk convert into an actual health event are the ones who never addressed the underlying cause because they believed it was just aging. The people most protected are the ones who treated the symptom as a signal, found the cause, and addressed it. This is also why I so strongly encourage the tracking exercise I mentioned earlier. Not because I want you to be anxious about your health, but because arriving at your doctor's appointment with a month of clear, specific observations is the single most effective thing you can do to ensure that your concern is taken seriously and investigated properly. Dry mouth is a symptom that gets dismissed easily. It is invisible to anyone except you. It does not show up on a scan or a standard blood panel, and it is common enough that many clinicians have normalized it. A log that shows a consistent pattern over 30 days, correlated with medication changes or nighttime waking frequency, is a clinical document. It changes the nature of the conversation. You deserve to have that conversation. There is one more area of research worth mentioning: the connection between oral health and cognitive decline. Several large studies have found associations between gum disease, tooth loss, and elevated risk of cognitive impairment in older adults. The proposed mechanisms include chronic inflammatory signals from the oral environment traveling through the bloodstream and affecting brain tissue. This research is ongoing, and the causal picture is not fully established. But the association is consistent enough across multiple large studies that it has prompted serious scientific attention, and it adds another layer to the argument that oral health in older adults is deeply connected to overall health in ways that matter. Now, let me talk about what actually happens at a medical appointment when you raise this concern. A thorough evaluation of chronic dry mouth in an older adult starts with a full medication review looking specifically at combined anticholinergic burden. It includes questions about sleep quality and nighttime breathing. It includes checking blood sugar if that has not been done recently. It may include autoimmune screening if dry mouth and dry eyes are both present. And it includes an assessment of the oral cavity itself. Not every appointment will include all of these things. Knowing what a thorough evaluation looks like allows you to advocate for the parts that are missing. You can ask, can we review my full medication list for anticholinergic effects? You can say, I have both dry mouth and dry eyes. Could this be autoimmune in origin? You can say, I wake 2 to 3 times a night with a severely dry mouth. Could we discuss a sleep evaluation? Specific questions get specific responses. Vague complaints get generic answers. Many older adults, particularly those who grew up in an era when you did not question your doctor or take up too much clinical time, feel uncomfortable advocating for themselves in medical settings. They downplay symptoms. They accept the first answer they are given. They leave with their questions unasked. If that resonates with you, hear this clearly. Asking for a thorough evaluation of a symptom that affects your quality of life every single day is not being difficult. It is being an informed, engaged participant in your own healthcare, which is exactly what the best clinical outcomes depend on. You have paid attention to your body long enough to know when something is not right. That awareness is an asset. Use it. For the next 30 days, track your morning dryness level, your nighttime waking frequency, and any medication changes. Bring that record to your next appointment. Use the patterns to ask specific questions about medication burden, sleep evaluation, and systemic causes. That is the action step. It is simple. It is concrete. And it is exactly the kind of thing that turns a dismissed symptom into an addressed one. Dry mouth is not the problem. It is the alarm. The danger is not the dryness itself. The danger is what the dryness allows. Bacterial overgrowth, silent aspiration, medication toxicity, nutritional decline, and over time, the downstream consequences of all of those things happening quietly in the background. You just spent the last hour understanding something that most people in your life have never thought about deeply. That knowledge is yours. Use it to ask better questions, to push for better answers, and to protect the health you have worked hard to maintain. Aging does not mean accepting decline. It means paying attention earlier, and you just did exactly that. In the next video, I am going to walk through one extremely common bedtime habit that most adults over 60 were told was good for them, but that quietly worsens overnight dryness and increases the bacterial load in the mouth while they sleep. It is not obvious. It is something that shows up in almost every senior household I have ever visited professionally. And once you know it, you will not be able to unsee it. I will see you there.